started. My name is Margaret Cuomo. I'm a nurse practitioner at Columbia University Medical Center in New York City, and I'm happy to be joined today by Dr. Justin Groden, who is the director of the Cardiac Amyloidosis Program at UT Southwestern. And today we are going to be talking about the practical management of Transthyretin cardiac amyloidosis. A couple of things to go over here. I would like to firstly thank Alnylam for providing the educational grant to make this talk possible. Program management services are provided by Vox Media, and this symposium is sponsored by the AAHFN. So please, if you could take a moment right now to complete the brief questionnaire that has been distributed. Staff will be collecting the questionnaire as we begin the program. Attendees may earn continuing education credits by attending the meeting and completing the evaluation for the AAHFN annual meeting sessions. You can see our faculty disclosures in the handout and also the presentations. And please complete the evaluation for this symposium in the handout. Representative slides are included with your handout and also available on the app. Presentations may be viewed later on Medscape. Question cards are going to be distributed. Personnel will collect cards throughout the program, so if you have any questions, feel free to write those down and they'll be passed out to us at the end. And please turn off all electronic devices to silent mode. All right, so with all that being said, we'll get started. So again, we're going to be talking about the practical management of Transthyretin cardiac amyloidosis. So we'll be talking about some foundational information about cardiac amyloidosis and then hopefully some practical kind of take-home management strategies for taking care of this patient population. Okay, so we'll start with when you should think about Transthyretin cardiac amyloidosis. Here are my disclosures. For this section of the talk, we're going to define cardiac amyloidosis, differentiate between AL and ATTR cardiac amyloidosis, recognize populations that are at increased risk for the condition, identify clinical red flags that are suggestive of ATTR-CM, and then also recognize kind of key findings on labs, ECG, echo, and cardiac MRI. So what is cardiac amyloidosis? Broadly speaking, it's an infiltrative cardiomyopathy caused by the extracellular deposition of misfolded protein fibrils within the myocardium. Amyloid deposition leads to increased ventricular stiffness, progressive diastolic dysfunction, heart failure, arrhythmias, conduction disease, as well as extracardiac manifestations that we'll get into as well. There are two main types of cardiac amyloidosis. So there's light chain or AL amyloidosis, and then transthyretin or TTR amyloidosis. Transthyretin cardiac amyloidosis is further subdivided into variant or hereditary TTR and wild type, sometimes we call age-related TTR. And just a closer look at those two subtypes. So AL amyloidosis, most of you are familiar with, but this is a plasma cell dyscrasia. So the protein that's implicated in this process is coming from the plasma cell. The light chains, it's not genetic. It progresses rapidly. We consider it a medical emergency when we detect it in practice. And we need to collaborate with our hematology oncology colleagues in the treatment of this condition because they're treated with anti-plasma cell therapy. These patients are younger, very sick, and again, we treat it as a medical emergency. ATTR amyloidosis is caused by a misfolded transthyretin protein. This is a little protein that is made mostly in the liver. This, as I mentioned, can either be due to genetic causes or age-related. It's a slow, the progression of this condition is slower and is treated with TTR-targeted therapy, which we'll get into later. So just to break it down, again, TTR is a small transport protein made over 90% in the liver, a little bit in the eye, a little bit in the brain, but mostly in the liver. It's a tetrameric protein, so there's 4 identical subunits that are kind of clicked together in this tetrameric shape. And due to either aging or a switch in the genetic code, that protein becomes unstable, falls apart into amyloid fibrils that then get deposited into tissues and organs where it's not supposed to be and cause dysfunction. In the heart, this can lead to conduction issues, arrhythmias, a restricted cardiomyopathy, progressing to heart failure, conduction disease. And in terms of the causes of this condition, wild type, we chalk up to the aging process because there's no genetic cause that can be identified in these patients. And a variant or hereditary amyloid, it's a single amino acid mutation in the TTR gene that leads to the condition. There are a lot of mutations that can cause this. There's over 130 known pathogenic mutations that can result in variable phenotypic presentations. This is a visual of the more common pathogenic variants that you may see in practice, just to highlight a few. There's V122-ILE or 142, depending on the nomenclature. And this is endemic in Black or Afro-Caribbean patients. 3 to 4% of Black Americans have this gene. And these patients present predominantly with a cardiac phenotype. On the other end of the spectrum, there's V30M, which is also called the Portuguese mutation. When this is an early onset phenotype, these patients have predominantly neuropathic phenotype. Another mutation that you may see in practice is T60 or T80A mutation. We call this sometimes the Irish mutation because we see it mostly in our Irish patients. And this has a cardiac and neuropathic phenotype, so sort of a mixed phenotype. But as you can see, most of these mutations have a little bit of both. So what populations should you be considering ATTR cardiac amyloidosis? As we know, it's underdiagnosed and more common than previously thought. So this is some data pulled from different screening studies, but 12% of patients with HFpEF have been found to have cardiac amyloidosis and shouldn't just be exclusively thought of in HFpEF patients because there's a significant amount of HFrEF and also heart failure with mildly reduced ejection fraction patients that can have this as well. A paper published 2017 by Dr. Castano did a study at Columbia looking at patients undergoing TAVR and found that 16% of elderly patients with severe aortic stenosis undergoing TAVR procedure had concomitant cardiac amyloidosis. So it's not a rare disease, especially in older heart failure populations. You're probably already taking care of these patients if you don't know it. And there are clinical red flags that should clue you into this diagnosis. Starting on cardiac manifestations, some of these we touched on, but classic heart failure symptoms can be seen. Aortic stenosis is not uncommon in this population. A lot of these patients have conduction system disease. Some require pacemaker placement. Atrial fibrillation is overwhelmingly common in this patient population. And then extracardiac manifestations are red flags to be aware of that can clue you into this diagnosis. Upwards of 80% of patients have preceding orthopedic interventions, including shoulder, hip, knee procedures or replacements, carpal tunnel release, spinal stenosis with spinal surgeries, bicep tendon rupture. So the orthopedic manifestations are very predominant in this condition, especially for wild-type TTR patients. And a lot of the orthopedic manifestations precede the diagnosis by 5 to 10 years, so it's a good clue when you're taking your histories. Other extracardiac manifestations include neuropathy, especially in our hereditary patients who can have a progressive peripheral polyneuropathy, as well as autonomic dysfunction. And this is just a closer look at the orthopedic manifestations. Just a plug to put it into your review systems when interviewing new heart failure patients or even existing heart failure patients. As you can see, very common, and particularly carpal tunnel syndrome. Almost 60% of patients have had that in their history, and this is in ATTR. And looking at a special population that we should all be cognizant of in screening for amyloid is Black patients or minority patients. So looking at data from SCAN-MP, which is a screening study for cardiac amyloidosis with nuclear imaging in minority patients. This is a study done at Columbia, Boston, Connecticut, was screening patients who either are Black or Afro-Caribbean Hispanic, greater than age 60, who had heart failure and an ejection fraction greater than 30, and an increased wall thickness greater than 1.2. So screening, just with those parameters, they found that there was a 6.6% prevalence of ATTR-CM in these patients. It was age-dependent penetrance as well, so once patients were over the age of 75, that rose to 11.7%. If you were Black and older than 75, that rose even further to 17.5%. And of note, 50% of these patients actually had wild type, so it's not just variant TTR in these patients. So if you have an older Black patient with unexplained heart failure, you should be considering cardiac amyloidosis. In terms of laboratory findings, some common ones that you might see would be a low level troponin elevation, so just above, sometimes just above the cutoff of the norm and persistently elevated, despite no recent cardiac events. Also, NT-proBNP elevated out of proportion to symptoms, and this is because of myocardial injury from the amyloid infiltration, increased wall stress, and heart failure syndrome. On ECG, some clues for cardiac amyloidosis would be, we classically think low voltage, pseudo-infarct pattern, and conduction issues. However, looking further at this data, you can see low voltage is not the most sensitive parameter when looking at ECG. Only some studies say 25 to 40% of patients have low voltage, so you're definitely going to miss a lot of patients if you're waiting for them to develop this on EKG. It's more accurate to look at voltage to match ratio, which we try to do in clinic. There's different tools online to help you calculate that. And echocardiogram is a lot of times the initial screening test of choice. You can find a lot of classic signs on imaging here, including thickening of the walls of the heart, the intra-atrial septum, valve thickening, biatrial enlargement, preserved ejection fraction if patients are early in their presentation, but can also have systolic heart failure or low ejection fraction if late presentation. And if your institution does strain, you'll often see this, what we call cherry on top presentation, where the apex is moving better than the base. And cardiac MRI has a lot of characteristic findings as well. Notably, ECV is gaining a lot of attention as a marker for cardiac amyloidosis with greater than 40%, usually in patients with ATTR-CM. I think there's been a lot of attention on amyloid at this conference, which is great. So hopefully everybody's kind of getting familiar with the red flags and how to pick this up in your own practice. So definitely just keep it in your differential so we can, make these diagnoses early and get patients on proper treatment. And with that, I'll turn it over to Dr. Groden to talk about diagnosis and treatment.
Thanks, Margie. That was a great talk. Can you all hear me? Good afternoon, everybody. This is always a terrific opportunity to have a chance to speak with you all at this meeting. These are my disclosures. Okay, so the outline for my talk, believe it or not, there are only 2 data points, but there is a lot to go over for these 2 data points. And for some of the topics that will have some overlap with Margie's talk, I will try to be a little bit more efficient with those items. Okay, that's my first slide you all missed. These are my disclosures. And now we can get back to where we were. So I know you guys were imagining what those data points were, but now you can see them. Are we good? Okay. So the 2 topics that we're going to go over are the diagnosis of cardiac amyloidosis and the treatment. And as I was saying, for some of the topics that will have some overlap with Margie's talk, I'm going to be a little bit more efficient with my slides just because I don't want to just beat the drum unnecessarily. So as Margie said, and she highlighted a really, really important topic, when people ask me all the time, how do you diagnose cardiac amyloidosis? And as you'll see, it's actually not that difficult. The harder part is trying to build a case that you should think about it. That's typically the activation energy, is if you ask yourself, could this be a patient that has cardiac amyloidosis, you will find that that's really the rate-limiting step. So there are a number of red flags or clues that we can look for. So individuals with heart failure or individuals with thick heart muscle that has no good explanation. So somebody that might have they don't have hypertension, yet their heart muscle is really, really thick. This should at least set off a clue that you should think about cardiac amyloidosis. I think this one speaks for itself. Anybody with an unexplained restrictive cardiomyopathy. Anybody who has heart failure with a history of bilateral carpal tunnel syndrome, in particular if they're older than the age of 65. Anybody who has a cardiomyopathy and an atraumatic biceps tendon rupture. Anyone with an unexplained neuropathy. So what do I mean by this? You see a patient with HFpEF or heart failure, similar to what Margie was describing, and they have neuropathy that might be out of proportion to maybe diabetes that they might have that really isn't that bad. Or maybe they had some toxin exposure and it doesn't really explain how severe their neuropathy is. This should set off a clue that that person could have amyloidosis. Anybody with orthostatic hypotension that has heart failure or a cardiomyopathy. Again, this isn't that specific, and we see a lot of orthostatic hypotension, especially as people age. But when it's disproportionate to what you expect and somebody has heart failure, you should at least consider a diagnosis of amyloidosis. And then anybody with hypertrophic cardiomyopathy that's diagnosed over the age of 60. So Margie highlighted a number of useful diagnostic tests that will heighten your suspicion or serve as clues that somebody could have amyloidosis. So we use these all the time. Many of you are familiar with echocardiography, ECGs, cardiac MRIs. These are great tests, but remember, they are not amyloid specific. All they do is they say, this heart looks like an amyloid heart, or this could be an amyloid heart. Okay, so now let's pivot to some amyloid type-specific tests. And in the next few slides, I'm going to go over each of these bullets individually. We're going to talk about workup for an abnormal M protein with free light chain assays, nuclear medicine scans with technetium pyrophosphate, and then we'll finally end on tissue biopsy. Okay, so this, even though we're talking more about ATTR cardiac amyloidosis in this discussion, this is probably the most important slide I have on my talk. You heard a lot in Margie's talk that AL amyloidosis is a medical emergency. So the most important test anybody can get, or the most important, actually I should say, I always told the residents and the fellows that if you don't get anything but serum free light chains, you're doing a good job. This is the most crucial test because you have to rule out AL amyloidosis to consider ATTR. That's a diagnosis you don't want to miss. And if you do nothing else, order serum free light chains. They are 91% sensitive by themselves to rule out, to rule in AL amyloidosis. Now, when you combine those to serum and urine immunofixation, you can see the sensitivity is almost perfect. So, and a very important point is that serum and urine protein electrophoresis, or SPEP and UPEP, they're actually pretty insensitive, so you really shouldn't be measuring these in isolation to rule out AL amyloidosis. If they're negative, you still have not completed the rule out. So now I want to talk about a non-biopsy approach to diagnose ATTR cardiac amyloidosis. So there is a non-invasive way to diagnose this disease if we've successfully ruled out AL amyloidosis, and that is using cardiac scintigraphy with a bone tracer that is essentially repurposed to diagnose cardiac amyloidosis, or ATTR amyloid. So what I've shown here is a simple grading scheme. So this is a semi-quantitative scale, and if you look kind of on the spine, you see that the area where the heart is, so it's right between the ribs, looks progressively darker as you move from left to right on the slide. And it goes from grade 0, grade 1, which these are ATTR negative, all the way to grade 2 or 3, where you can see that the uptake is either equivalent to bone or is greater than bone, these are positive tests. So this is actually quite straightforward. And if we combine them with a negative workup for an abnormal M protein, you can see that the specificity and positive predictive value is actually excellent for this test. So for individuals that have no abnormal M proteins, we can get a non-biopsy type-specific diagnosis of amyloidosis. Okay, so this is bone scintigraphy for the heart 103, not 102. So we typically pair this with SPECT-based imaging. So those grayscale images I showed you on the last slide were planar images. So kind of the patients like this, we take a picture. So this gives you a three-dimensional representation of where the uptake of the tracer is actually occurring in the myocardium. And you can see that both of these scans, I didn't show you, were actually read as positive. But when you look at the SPECT images, you can see that the area of orange on the panel on the left is inside the blood pool, not in the muscle. So this is a negative test. And if you compare that with the image on your right, you can see that all the uptake, now this is a very marked image, is coming from the myocardium. This is a true positive. So how do we put this all together? As I mentioned, the hardest part about diagnosing cardiac amyloidosis is thinking about it. You have to build a clinical suspicion. The first test we should get is your workup for an abnormal M protein. So if this is abnormal, then we cannot get a non-biopsy diagnosis, and you must get a tissue biopsy. I'll talk a little bit about tissue biopsy in the next few slides. Now, if you have no evidence of an abnormal M protein, and you have a positive PYP scan or a positive cardiac scan with a bone radio tracer, then you have solidified a non-biopsy diagnosis of ATTR, and then we move towards genetic testing. Now, let's say that the light chains are normal, your nuclear medicine scan isn't helpful or it's negative, then you have two choices. It's either not amyloidosis, or if you're still suspicious, then you should biopsy that individual and keep chasing the diagnosis. So, again, a key point, if there's ever any ambiguity in any of these testing, you can always fall back to the gold standard and biopsy these individuals. So at our institution, the highest yield tends to be endomyocardial biopsy. There's some data that suggests it's 99% sensitive for the diagnosis of cardiac amyloidosis. I can tell you that in practical experience, it's probably not that high, especially in patients where the amyloid deposition is probably not as severe. We just might not, you could easily miss a patch, but in general, amyloid deposition is pretty diffuse in the myocardium, so there's a high likelihood that you will actually get a piece of amyloid tissue. It actually has a very acceptable risk. So then once a biopsy specimen is sent to pathology, they stain it with this amyloid stain. Typically we use Congo red. If that's positive, it says this is amyloid, yes or no. It does not tell you what type of amyloidosis is. So additional tests need to be ordered on that specimen. So at some institutions, they'll use immunohistochemistry to differentiate the types of amyloidosis, or they might send it out, or they might do this in-house, where they might run mass spectroscopy or mass spectrometry, and then they can truly identify what that protein is. You have to do both steps. We see all the time that a lot of referrings to me will complete the Congo red staining, but not follow through with the typing. And so a quick word about FATPAD. So for those of you that may be familiar with this test, it has varying levels of sensitivity. It's different for the different types of amyloidosis. I can tell you at our institution, we really don't incorporate it into our practice because we have a ton of false negatives. And so essentially what we're doing is we're just delaying the diagnosis, especially if we're worried about AL amyloidosis, and it's just using time. Now, at other institutions, they have much higher yield. It's very pathologist dependent, sampling dependent, and then it's much harder to stain than myocardial tissue. So like I said, at our institution, we just go for the target organ biopsies. So another key point is that a negative FATPAD biopsy is not sufficient to rule out cardiac amyloidosis, especially if you're highly suspicious for it. So a quick word about genetic testing. You heard a lot about different variants, especially in individuals of Western African ancestry from Margie's talk. So in general, TTR gene sequencing is recommended in all cases of TTR-related amyloidosis. So fortunately, we have sponsored testing, and it's actually quite easy to get the TTR gene sequenced for a number of our patients. They can get something in the mail, they swab their cheek, and then we can get the result in a couple weeks. So clinical grounds in history are actually quite limited. Because this disease was really underdiagnosed historically, and some could argue still is, clinical grounds in family history really aren't that useful. Okay, so tying all this diagnosis together, there are a few take-home points. Beware of red flags or clues. Nuclear medicine or cardiac scintigraphy with bone tracers are only diagnostic if you've ruled out AL. If there's ambiguity in any of your testing, then biopsy. Now, to treat these individuals, you must get an efficient type-specific diagnosis. Okay, so now the second quick bullet that we're going to go over is the treatment of cardiac amyloidosis. So we're really going to focus on transthyretin. So I'm going to very, very quickly go over the pathophysiology of TTR amyloidosis. So TTR, as you heard from Margie's talk, is made in the liver, and then it circulates in the blood as a homotetramer. Okay, so we have several classes of drugs. The ones that we're going to be focusing on are the TTR silencers and then the TTR stabilizers. So the TTR silencers are medications that inhibit hepatic production of TTR. So if you take one of these medications, there is no TTR floating around in the bloodstream. These medicines are small interfering RNAs, antisense oligonucleotides, and currently in clinical development, there's a CRISPR-Cas9 based treatment. So single base pair editing, and where individuals can have lifelong knockdown of TTR after just one infusion. And then there's another class of therapy called the TTR stabilizers. These are molecules that bind to the thyroxine binding site. So these are these little red dots that I show on the cartoon up there. And essentially what they do is they stabilize the protein so it doesn't break apart and doesn't cause ATTR amyloidosis. And they're also molecular mimickers that mimic protective genotypes. In other words, individuals are amyloid protected because of different mutations. There is a drug called acoramidis that mimics these mutations. So, and then we'll finally talk about really the holy grail, which is the depleting amyloid deposits. I mean, this is the most common question patients ask. How can you get this out of me? Is there a cure? So there's two methods. There's organ transplant. Many of you might do this in your practice. And then there are monoclonal antibodies that are designed to activate the immune system to deplete amyloid deposits. So I'm first going to show you some data from TTR stabilizers. So the first TTR stabilizer that came on the market in 2019 was tafamidis. This is a benzoxazole derivative that binds to the thyroxine binding sites and halts the production of ATTR by stabilizing the protein. And when given to individuals with ATTR, both hereditary and wild type, with heart failure, you can see that there was a dramatic improvement in outcomes over time, both death and hospitalizations. And I'm not going to show the data, but these individuals also had a slower decline in quality of life and a slower decline in functional capacity. Now I'm going to sound like a broken record, but every agent that I'm going to talk about has those effects, which is very important because even though I'm showing you survival curves, that's really what's important to a lot of these patients. How am I going to do maintaining their self-efficacy, maintaining their functionality? So, and as I mentioned, tafamidis, and you'll see this pretty consistently with all these medicines, translates to a dramatic reduction in cardiovascular hospitalizations. So these are important data because it puts into context the use of the impact of these medications on the health system, that it may reduce this type of burden. And so when do we use them? Actually, so these medications stabilize the disease. So it stands to reason that if a patient has very, very advanced ATTR amyloidosis, then they might progress beyond a level with which can be treated. So the earlier we treat, the better. And these are data from a track that demonstrate that. So the second stabilizer that has come on the market was approved just a few years ago is acoramidis. This is that molecular mimicker. And when this was tested over 30 months, you can see that this was also associated with a substantial, there were lower rates of death, CV hospitalizations, and these individuals had lower NT-proBNP and 6-minute walk and greater 6-minute walk distances in comparison with individuals that were randomized to placebo. And then when they were followed even longer, so individuals after the trial was completed, they had an open label extension, and you can actually see that there was a substantial, there was a lower risk of mortality and cardiovascular hospitalizations almost out to 4 years, but it's 42 months, 3.5 years. So now I want to pivot to TTR silencers. And the first silencer that I want to talk about is vutrisiran. Vutrisiran is a small interfering RNA that is injected subcutaneously every 3 months, and it targets the liver, and then it silences the production of hepatic TTR. So this was evaluated in the HELIOS-B clinical trial. These were individuals with ATTR. The majority of them had wild-type ATTR, and they also could have been on tafamidis. There was a proportion of these individuals that were already on an existing therapy. And out to 39 months, you can see that vutrisiran was associated with a lower risk of death from any cause or recurrent CV events. And so, as I mentioned, there were individuals that were also on stabilizer therapy with tafamidis. And if you look at these two panels on this slide, you can see that despite being on stabilizer therapy, in the overall population versus those that were just on, there were individuals that were on 2 drugs and individuals that were on 1. Their randomized drug and then their pre-existing tafamidis. And you can see that for the individuals that, thank you all for your patience. You can see constancy of benefit whether they were on tafamidis or not, or if it was a mixed population. And then when we look at the different subgroups, you can see that the effect was largely constant when you stratify by NYHA functional class, NT-proBNP. You can see it was largely the same, especially when we look at either the composite of all-cause mortality and CV events or just all-cause mortality alone. And then I know this is a busy slide, but if you bring your eye towards the all-cause mortality panel and you look at the NT-proBNP strata, you can see that there is the suggestion that individuals with lower NT-proBNP levels, which is a surrogate for being less sick, seem to achieve a greater benefit from the drug. Again, so perpetuating that theme that we saw with tafamidis. And then now I'm going to touch on, this is just a quick word on eplontersen. This is an antisense oligonucleotide that is given every month. And this is from a company, this is for AstraZeneca, will be taking this to the market. This is currently being studied in a phase 3 clinical trial for ATTR-CM. It is currently approved for ATTR polyneuropathy. And CardioTransform, this slide just demonstrates the study design. You can see that it's huge. This is quite an ambitious study. They randomized 1,400 individuals with ATTR. This will also give us an opportunity, because there was strata for both tafamidis and non-tafamidis use, really to understand whether there is any differential benefit for individuals that were already on pre-existing therapy. Now, when we compare the clinical trials, you can see one thing that I want to show you is that if we look at the ATTRACT clinical trial for tafamidis, the acoramidis clinical trial, which was ATTRibute-CM, and HELIOS-B for vutrisiran, you can see one key thing. These were all conducted over different eras. And if you look midway through this table, when you look at the proportion of ATTR wild type to hereditary ATTR, You can see now that the more contemporary trials, so ATTRibute-CM and HELIOS-B, are predominantly ATTR wild type, so a much lower risk population. In fact, these individuals in the latter two trials were actually diagnosed much earlier. So individuals in ATTRACT had heart failure, there was nothing that they were being treated with, and they were waiting for something. And so this was very different than the population that was enrolled with ATTRibute-CM or HELIOS-B, where they said, hey doc, I've got this disease, and we'll say, okay, if you're on your tafamidis for 2 months, you can be randomized into this trial. So they were diagnosed in a very different stage of the natural history of their cardiomyopathy. And then when we think about these trials and we compare the baseline mortality rates of the placebo groups, you can see that individuals with ATTR, and we don't exactly know why this is, it could be from a variety of reasons, but they're getting lower and lower risk. Now, this might be a confluence of maybe we're diagnosing the disease earlier. Maybe we're just seeing a greater proportion of wild-type ATTR that wasn't there. Maybe these individuals are getting wonderful medications like mineralocorticoid receptor antagonists, SGLT2 inhibitors, or they are being referred to centers with expertise in their management, such as Columbia, or UT Southwestern, or many centers that you all work at. Again, so I think it's really important to think about this, especially as we compare drugs of different classes within this population, that the underlying mortality rates are all quite different. So this is quite a busy slide, but it really just highlights a glimpse into the future, that if you look at a lot of the red rectangles, there are a number of drugs, both in the silencer class and in the depleter class, that are currently under clinical investigation. So expect a lot more changes, and this talk to get even longer in the future. Okay, so now I'm going to end on some practical tips. So TTR stabilizers increase serum TTR when administered. They stabilize the protein. So if you were to measure a blood test, you can get prealbumin, which is another name for TTR. Those levels go up. TTR silencers, because they block the production of TTR, those levels go down in the blood. Now, another key point is that patients that are on TTR silencers need to take supplemental vitamin A daily. And the reason for that is that for every TTR tetramer that floats around in the blood, it is complexed with 2 molecules of RBP4, or retinol binding protein 4, that transports vitamin A. So you deplete TTR, you can't transport vitamin A in your bloodstream. So this is my last slide, and again, I want to salute to all of you for having this meeting, inviting me, and listening to our talk.
Thank you so much, Dr. Grodin. That was wonderful. All right, we're going to end with a quick kind of rapid-fire question session, which should be fun. Is it going up? Okay. So I think you want to take turns? You can ask me. All right, so the first question.
So the first question is, what are the essential criteria for the non-biopsy diagnosis of ATTR-CM?
So I think I'll just quickly breeze through this because you did such a fabulous job of covering this in your talk. But just to drive home, it's important for everybody to have this on their differential. If you're not thinking about it, you can't diagnose it. So if you have that clinical suspicion with those red flags that we both reviewed, paired with some imaging that kind of clues you off to something might be going on that resembles cardiac amyloidosis, you can proceed to the diagnostic workup. Key in this process is, of course, can't underestimate the importance of ruling out light chain amyloidosis. So you're going to do those 3 simple tests, the serum free light chains, the urine protein electrophoresis with immunofixation, the serum protein electrophoresis with immunofixation. And if all that looks good, you can proceed with your pyrophosphate scan. And if anything comes up, as Dr. Grodin said, abnormal with the light chain testing, you can proceed to endomyocardial biopsy. All right. And next question for Dr. Groden. So talking about practical management of this condition, what heart failure specific therapies should patients with ATTR-CM be treated with?
It's such an important question because when we think about our typical cardiomyopathies, right, so somebody has heart failure with reduced ejection fraction or a dilated cardiomyopathy that's non-ischemic, or maybe they've got coronary artery disease, we have this menu, or this buffet, if you will, of different medications that we should put these individuals on. Beta blockers, ACE inhibitors, ARBs, ARNIs, MRAs, SGLT2 inhibitors, and there are a wealth of data that support their use and they're beneficial. In fact, you know, we get kind of flogged and that we're doing a bad job if we're not putting individuals with heart failure on these medications. Now, for cardiac amyloidosis, whether their EF is preserved or reduced, it's really not clear if they respond to any of those therapies. So there's a number of points to consider. So in a lot of those clinical trials, individuals with cardiac amyloidosis, if it was known prior to randomization, were excluded from the trial. So there is an absence of data. And then a very practical point, many patients with cardiac amyloidosis really can't tolerate those medicines, right? You heard us talk about orthostatic hypotension. They might have autonomic dysfunction. They might be intolerant of their blood pressure medicines, or they might even be scaling back their antihypertensives as a red flag that they might have amyloid. So really the use of some of these medications becomes quite impractical, especially with no proven benefit. That being said, you know, there are several patients with ATTR or even AL that don't meet some of these criteria that may be able to tolerate some of these medicines from a blood pressure standpoint. And so I don't think it's unreasonable to try to use them, but I wouldn't be so dogmatic as trying to force the issue and making sure that they're taking these therapies. Now, what do we do? So we typically extrapolate a lot of data from HFpEF clinical trials, and we kind of imprint that and assume that this is beneficial for individuals with cardiac amyloidosis. So a number of our patients are on mineralocorticoid receptor antagonists, spironolactone, eplerenone. Now there's some newer agents as well, and then SGLT2 inhibitors. Again, this is literally transitive. We just infer from HFpEF that they might also be beneficial. Empirically, even though there are an absence of randomized data, empirically it does appear these do benefit these individuals, but again, they're also being managed by chronic disease management programs like the one that Margie's a part of. So again, they're there. I wouldn't force them. So especially for heart failure medicines for HFrEF, they're challenging to implement. Some patients may tolerate them. The benefit's unclear. And then we typically use more conventional HFpEF treatments in the long term, again, with some uncertain benefit. Okay, so how do I monitor ATTR-CM disease progression in my ATTR-CM patients who are taking disease-modifying therapy?
Yeah, so this is a great question. You know, we definitely get asked from patients all the time, like, how am I doing? Am I progressing? So it's sometimes satisfying to give them an answer that comes from a consensus statement. So, I mean, this information was published in a JACC heart failure guideline documentation that came out earlier this year. And important to note, this experts focused on signs of disease progression, not necessarily amyloid deposition progression. So they made that distinction because we don't, at this point, have a measurement that says you're getting more amyloid in your heart or not. It's more, is the condition overall progressing? And they chose parameters that were kind of easy, you know, practical to collect during clinic visits, that was stressed, and also backed by evidence, so had prognostic implications. So these fell into the buckets of clinical, biomarkers, and functional. Clinical, heart failure-related hospitalizations, of course, and then outpatient diuretic intensification has become a big focus point of research and possibly, you know, future endpoint for studies. If we're trying to think of other things besides hard endpoints, you know, we see escalation of diuretics definitely can clue us into progression of disease. And then cardiac biomarkers, NT-proBNP we do check, and they came to the consensus that an increase of over 700 or a 30% increase was considered progression with this lab, and then also decline in kidney function. Functionally, which is probably the most important thing for our patients, would be what they're able to do. So their change in 6-minute walk test as a reflection of their functional capacity, and then their patient-reported symptoms as captured by KCCQ. So a change in 5 points was considered progression. So experts recommended collecting these data points annually to see if there's progression in their condition.
Margie, I'm curious as to what you guys think about, at Columbia, because there seems to be a disconnect, right? There's amyloid, there's progression of the amyloid disease. I think you hit on that point, right? You get more fibrils in the heart, or more fibrils in places you don't want them in the body. But then some of these markers could be nonspecific and could just be the person sick, or might be a result of maybe a downstream result of a number of other comorbidities because of a life they've lived, right? For no better way to put it. So, we have a patient in our ICU who is a 71-year-old man who has hereditary ATTR. It's V122I or V142I. He's been on vutrisiran, has a little neuropathy. His EF was low, which is really, really bad for patients with ATTR when you meet them. That tends to be a really advanced marker of disease. He kind of stabilized and was doing fine. His NT-proBNP didn't change, and about a year ago, we randomized him into a depleter trial. So great, this guy's getting everything. Now, we have no idea if he got placebo or not, but then he's now in our intensive care unit and has had worsening heart failure over the last several months and showed up in shock. And I'm just kind of curious as to, did you think, this guy was sick when we saw him, and, did his amyloid get worse? Or was he just succumbing to his natural history and could no longer compensate?
Yeah, I think it's an important question. I'm not sure I can answer. And I think the experts on this paper too made it clear we don't have a satisfying way to say the amyloid is getting worse, and patients want to blame the amyloid, and when their condition advances, they run to switch their therapies, which we'll get into, but we don't really have evidence for at this time. So it's a hard conversation to say, damage has been done to the myocardium, and this may just be a progression of the underlying myopathy related to the previous amyloid deposition. Which I think segues well into our next question. Is there any evidence for switching ATTR-CM therapies for combination therapy with currently available disease-modifying therapies? So switching from stabilizers to silencers, adding them on, what do you think?
I love this question.
The $1 million question, literally.
I love this question. We can be really, if it is $1 million question, was that a pun? It could be $1 million question. Yeah, if you're on, but we can make this very brief. The answer is no.
Right.
So what look, I kind of get on my soapbox when it comes to this. We're in a really fortunate spot because if you rewind the clock back till just the beginning of 2018 and earlier, right? So we've got the dawn of man up to 2018, there were no treatments for ATTR-CM at all. Then all we had was tafamidis. And now we've got 3 drugs that are all effective. They are all safe. So that was one key point that I left out. So remember, these individuals, they're typically older, right? This is a population where they're more prone to side effects from drugs or pharmacopoeia, et cetera, or medical complexity. These drugs are safe, they're effective, they're virtually harmless. In fact, if you look at the AEs from the clinical trials, there is a very striking peculiarity in that you see more AEs in individuals that were on placebo than were receiving these drugs. So they're great. So the drugs do have, if you look at molecularly, there might be some differences. So for example, acoramidis molecularly is a superior stabilizer to tafamidis in the way that it stabilizes the protein. Now, whether that translates to clinical benefit is not quite certain. So because of that, it's hard to know whether transitioning is the right thing to do or transitioning between classes. In other words, you go from a drug like tafamidis to acoramidis to a silencer like vutrisiran or maybe one day eplontersen. It's really not clear that you get a greater benefit from doing that. Now then, there's also the economical impact of this, right? I mean, these drugs are quite expensive. And so there's a lot of paperwork, there's a lot of office work that has to be done, there's a lot of information that has to be provided by the patients just to get on one of these drugs. So then when the benefit of adding a drug or switching a drug becomes uncertain, then, you know, kind of at least our appetite to go through all of that, or to, you know, the economical impact of putting somebody on another drug, it's hard to justify that. That being said, you know, we do have some patients that want to be on 2 treatments. You know, we typically don't hold them back for that. It's not a safety issue, but I highlight how uncertain this practice is. And, you know, I typically don't fight the insurance companies if they're not going to cover it. Now, we do have a number of people that are on dual therapy in the form of clinical trials. And then I think down the road, the dual therapy that everybody will probably need to have some consideration is that for somebody to be on a disease stabilizing medicine, either with a TTR stabilizer or silencer and a depleter. Again, so that's another combo therapy that, you know, maybe one day we'll be fortunate enough to talk about. So I think this is the last question, and this is great for you, Margie. So what are the roles of heart failure nurses in the management of ATTR-CM?
Yeah, I mean, I think there's a great you know, place for nurses and nurse practitioners in this wonderful patient population. You know, just first of all of you being aware of the red flags in clinical practice so that you can be the one to initiate the process of possibly working up these patients for this condition. A lot of times nurses and nurse practitioners are the ones going through the charts, writing the notes, taking the history, meeting the patients for the first time, follow-up exams, doing clearance for surgical procedures. So there's a lot of opportunities, I think, for us to pick up on these patients and make diagnoses. And of course, making referrals, coordination of care. There's a lot of, it's a very multidisciplinary condition a lot of times. We have to collaborate with other practices, community cardiologist, neurologist, orthopedics, gastroenterologist. So I think we're kind of masters of coordination of care, and there's a huge place for that with this condition. And then of course, providing education to patients and their families. I think there's still a lot of misinformation about cardiac amyloidosis. Patients are still Googling it and thinking they're dying in 6 months. So there's a lot of you know, hand-holding in the best possible way, providing good education for patients and their families, and kind of being there through this disease trajectory. And I hope to see more NPs and nurse practitioners involved with these patients because they're really special.
Yeah, and they're definitely needed.
Yes. All right, we're going to see if we have any questions from the audience.
So we have one question from the audience, and the question is, why is there a difference in the separation of curves between the ATTRACT and ATTRibute clinical trials? Well, there's a lot to unpack with that. You know, it could be an artifact of the study. Again, it's really hard because you have the underlying risks, right? If you recall that slide where I showed you that in the placebo arms, the risks of mortality was very, very different in the different trials. So basically, these were different patients in the different studies. So it's really hard to understand whether this is a point at which risk is different with the drugs when it starts to have an effect, or it's maybe just an artifact of who was randomized in the trial itself, and it might not replicate. Yep. So I think that's a great point, and this is something that a number of people have debated. You know, one thing that I always fall back on is that the drugs do work, and if you look across studies and we look at the non-fatal endpoints. So I think one thing we have to recognize is that this disease, specifically ATTR-CM, is slow. It is a slow buildup in the myocardium. It is slow to fix, right? But we do see implications of these treatments or effects of these treatments on quality of life, functional capacity very early on. So the drugs are doing something. It's just probably takes some time to have exposure where, you start to see those differences in comparison with placebo.
Another question from the audience asking about switching between therapies. If you want to switch a patient from a stabilizer to a silencer, should they remain on the stabilizer for a period of time before deleting it from their regimen? Do you just stop one, start the other? I would say we're not often switching patients from stabilizers to silencers in one replacing the other. But if we did, I don't think there's any reason you would have to continue on a stabilizer. Again, this is all evidence-free zone, I think. But if you're thinking about it, you're stopping the liver from producing the protein. So at this point, we don't have any evidence that you would need to be on both for a period of time for anything to work better. So we don't necessarily do any of that.
Yeah, but it's also very hard, right?
Yeah.
Because probably a number of other sessions at this conference have highlighted the importance of guideline-directed medical therapy for heart failure. There's combination therapy everywhere you look, right? That must be good for amyloid too. We just don't know. Go ahead.
I was going to say, do you anticipate a lot of questions being answered with the upcoming CardioTransform trial reporting out? Or?
I hope so, but it's still going to be complex, right? I mean, I think the dangerous part is there could be a slippery slope in the interpretation because the patients that receive tafamidis, there's probably something different about their medical team, maybe the countries where these individuals were randomized, right? What access to care that they had, right? So it's, and then where were they? Have they been on tafamidis for 5 years or 5 days, right? Again, that's a big difference, but so there's a lot that I think goes into it because they're not randomized at one time period. But it will be insightful. We just have to kind of hedge, I think, a lot of the observations. So I'm just looking at the time. We have one question. Okay, so this is pivoting from the combination therapy question. This is good. So the question is, do you find that for advanced amyloid disease patients, are inotropes or other advanced heart failure therapies viable options for delaying the inevitable? I assume you mean death.
The inevitable. I mean, we do have some patients on home, chronic inotropes, not to prolong life, but to make them more comfortable at home. So I don't think, they're excluded from this therapy. Do you practice similarly, or?
Yeah, we don't, for at least our ATTR patients, we don't use, well, for all amyloid patients, we don't use a lot of inotropes, but, for some, we feel that they can stabilize them, in particular if they're really, really sick in the hospital. They might not have the same response as a patient with a dilated cardiomyopathy. There are a number of reasons for that based on their physiology. They've got a tiny small chamber, and you really can't get the heart to beat harder like you could some of those other cardiomyopathies. And then in terms of transplant, a number of these individuals can do quite well. Now, AL and ATTR are very, very different animals. So for somebody with AL, there's obviously the malignancy risk. So that has to factor in to kind of the pre-transplant assessment of whether or not we should go ahead and do this. And then with ATTR, for a lot of individuals where the heart is really the only organ that's involved, they can do quite well with cardiac transplantation, obviously if they meet kind of the other medical criteria. And then one thing that we do, which is an evidence-free zone for now, is that once they've had ATTR, once they've had a transplant, there are many centers that will keep them on their ATTR, their disease-stabilizing medications.
Absolutely. All right, well, with that, I think we'll wrap it up. And just thank you so much, Dr. Groden, for joining me today, and thank you all for coming. And hope you have a great rest of your evening.
Yep. Take care, everybody.